So this is about the genicular nerve blocks. Okay. I know there's a lot of interest in the acute pain world about the genicular nerve blocks. So I'm going to have my chronic pain hat on and look into the acute pain side and see where it stands. So it is not really new, even though it is new for acute pain world. This has been there for quite some years. We first started in 2011, and Choi et al., this was the first description that came up as a black and white document in there. And at that point, we were only targeting 3 points, that is the superomedial group, infromedial group, superolateral group, not inferolateral group, because we were doing it X-ray guided. So when we put our needle in X-ray guided near the femur, you know that your common peroneal nerve is there on the inferolateral aspect. So we didn't want to burn, because we are burning the nerve at 80 degrees centigrade. So if you burn the common peroneal nerve, your patient will not be very happy with you. So we did not do that in our chronic pain world, which was just a 3-point introduction of the needle. And also the way we did it was like you place your needle almost like a parallel, so that you get the active tip of the needle coming in contact with the tissue. So you're producing a lesion, thermal lesion, to kill the nerves. This is the idea. So it is not like our conventional genicular nerve block in acute pain world. So the technique was slightly different. Now, this is a review article that came about the implications of diagnostic block and radiofrequency ablation. And in that one, 12 anterior and 6 posterior knee innervations were studied, included in that study. This is very important, because even though we say superomedial genicular, infromedial genicular, it is a group of nerves. It is not a single nerve. So if you look at here, you can see quite a lot of nerves comes and supply the anterior knee as well as the posterior knee. So in the superomedial group itself, you can have the genicular branch itself, which is coming from your sciatic component. You can have the obturator component. You can also have the infrapatellar branch coming in the medial aspect, or the saphenous nerve itself. And even though we say these are the nerves, they communicate often together as well. So it is not just one nerve you are targeting, it is a group of nerves in that region. Now, if you look at the systematic review and the meta-analysis of the effectiveness of genicular nerve blocks in chronic pain, this is something that we should always keep in our mind when we are using it in the acute pain side. That is that in comparison to the conservative treatment, the radiofrequency denervation significantly improved the knee joint pain, but limited response or limited improvement in the function. So when we are doing this for our postoperative pain in the knee surgery, we may be providing analgesia but not necessarily improving the function by adding the genicular nerve block into your paradigm. So what's the rationale adding the genicular nerve blocks into the knee surgery? As we know, the sympathetic nervous system has got an important role along with the sensory fibers for the pain relief that is originating from the cartilage, bone, and synovial pathology. So when you are doing osteoarthritis, these patients do have pain from the knee because of all this innervation. So motor sparing blocks are something that is very favorable for everybody, because you want to mobilize the patient as quick as possible. So if you add a sensory block rather than the main plexus block in your analgesic recipe, that is important and helpful for the patient. Genicular nerve block, compared to many other blocks that we perform, it's a very easy target to perform, especially under ultrasound guidance. If you can put a cannula in, you can do a genicular nerve block. It is as easy as it is. Now, the targets of the other nerves supplying the knee, because we were targeting, conventional was femoral and sciatic. Probably we covered almost everything except the obturator component, but that gave motor weakness previously. Then we went into adductor canal. Adductor canal is only targeting the medial aspect of the knee, and only 2 components of the innervation of the knee capsule, as well as your myotoe. So this is one of the reasons, if you add more sensory nerves into the recipe, you get more success. Persistent post-surgical pain. I can't tell you enough about this, because this is one of the big barriers for us. 1 in 3 patients after knee surgery come back to our clinic with the persistent post-surgical pain, and it is very difficult to treat these patients. Because once they cut through the tissues, you cut off all our targets, genicular nerves. Then we don't have much targets to treat near the knee joint. Then we have to go into the dorsal root ganglia or spinal cord stimulator and more expensive interventions like that. So the genicular nerves are our first target if you get a virgin knee, and we get very good success. And if you do the blocks before the surgery, you may have a benefit. I know there is no enough evidence out there at the moment, but we started doing it in acute pain world very recently. So wait for the future studies as well. It is part of the multimodal analgesia. And if you think about the pain pathway, you have got transduction, which is in the periphery, then the transmission through the nerves, then the modulation, which happens at the spinal cord and the dorsal root ganglion level, and the perception in the brain. So if you do a peripheral nerve block, it is not only the analgesia local area, but even up to the central nervous system, you can have the effect of the analgesia. Long-lasting pain relief seen in chronic pain patients. So when you come, a patient is coming for a knee replacement, you should consider this is a chronic pain patient. They are there for the knee replacement because of the chronic pain. So their pathology, their pathophysiology, and the physiological changes in the brain is as a chronic pain patient. We are adding acute pain on the top of the chronic pain. So the pathology needs to be treated as chronic pain rather than acute pain. So if the genicular nerve blocks are providing excellent analgesia from the osteoarthritis or the capsular level pain for chronic pain, if you add that into your acute paradigm, definitely that will add additional benefit for the patient. So the neuropathic pain, interestingly, the neuropathic pain in knee surgery patients actually develops from day 6 onwards. So when we see them, we want to do a sensory block, motor sparing block, get them walking after the spinal, send them home as quick as possible. That is our aim. And we completely forget the fact that these patients develop the neuropathic pain from day 6 onwards, and they are completely out of our radar. These are the patients get more and more opioids prescribed, and they end up in our pain clinic. So if you look at the anatomy very quickly, if we always divide that into 4 quadrants, the superomedial, superolateral, infromedial, and infralateral. From a practical point of view, you don't need to worry about the specific nerves. We are targeting the area almost like a fascial plane block. So these are the group of nerves, but don't forget the fact that anterior obturator and posterior operator, they can not only supply the posterior aspect alone, they can supply the anterior aspect too, especially by a communicating branch through the saphenous. Posterior knee, again we divide that into 4 quadrants, and the popliteal plexus do supply main part of it, but also you can get articular branches from the sciatic nerve itself. This is also important in the posterior aspect. So if you are truly talking about the genicular nerve blocks, you should include both anterior as well as posterior. So anteriorly, we have an intermediate group as well. We don't normally talk about it because it supplies to the lateral and the medial side as well. Okay, so from technical point of view, we use a slightly different technique in our chronic pain world. I will tell you why, and it is important for you to get better success as well. So this is the conventional scanning technique, knee position for most of the acute pain physicians. There is a problem here. When the knee is straight, you have that your quadriceps tendon very relaxed, and the tissue is quite kind of flabby there. You put your probe in there, you will not get very good results. How we do? We slightly flex the knee and externally rotate. So if you do that, what happens is the muscles will become really tight and you have a better visibility. Why we started doing this? Because for the radiofrequency denervation, I don't know how many of you know that, we use a rather large needle, and that will be connected to an electric wire as well. So you need to have a very stable needle in that position to do the radiofrequency. That is why we developed this technique. But even for the acute pain, this particular position will help you to identify the nerves and inject in the right place without significant problems. So for the lateral aspect, the other way around, slightly flex the knee and internally rotate it. So Supromedial genicular nerve, as you can see, what you are looking is the junction between your shaft of your femur and your epiphysis. Yeah. So the condylar part, that is the metaphysis and the epiphysis junction. There you will see the tissue is starting to become slightly bigger because the capsule is starting and the genicular nerve and the artery will be there. Now in most of these pictures, because this is taken in a healthy individual, you will see the artery. I'll be very honest with you, in a very arthritic knee, you don't always see the artery. So the surrogate marker artery is not always helpful. So in this video, you can see the pulsation very, very briefly. I will put that once again to see that. You can see the artery pulsating. That is your surrogate matter for your supromedial group. And this is, I do out of plane, and this is where I put the needle. So I come from the lateral to medial aspect, even in this position. The reason for that is when my injectator will go towards the intermediate group of my genicular nerves. The infromedial genicular, it is the inferior part. It's the same principle. You look for the shaft of your femur becoming your condyle. Again, you can see the artery pulsating. This is the target. Even if you don't see the target as artery, you put the local anesthetic in there, you will get all the group of the nerves. Superolateral, you tilt the patient's leg into internally rotated, and probe position is as same. But at this level, the lateral aspect, the kind of takeoff of the bone is not as dramatic as the medial side. Again, you will see the artery pulsating. You will be able to inject. I go out of plane. Again, this time I come lateral to medial so that I get the intermediate group in that. Inferolateral group, you will not see this technique described in the chronic pain world. The reason for that is we never did it. We were worried about the common peroneal nerve. If you are going to do this, I do this for acute pain. If you are going to do is, what is important is you need to identify the Gerdy's tubercle. The Gerdy's tubercle is the tubercle where the ligament is coming and attaching, and your the recurrent fibular nerve curves around it. So if you identify that tubercle and put your probe on the top and inject from lateral to medial, very low concentration, you will not get your common peroneal nerve. So this is slightly different anatomy. So no anatomy you would see compared to the other three sides. You don't see that kind of the shaft of the femur becoming like a curved uptake. Yeah? And you will be able to see the pulsation there as well on the top. So you can inject a very low concentration, very low from posteriorly as your eye pack, you can do that very easily. That will cover all your genicular nerves. So which nerve block is enough for the total knee replacement perioperative pain? We need to think about the osteotome, dermatome, myotome, and sclerotome. You are treating a chronic pain patient. Your chronic pain patient is becoming acute on chronic pain patient who may end up having persistent pain. So you need to consider all these things in your brain when you are doing the block for this patient. You need to block somatic, neuropathic, as well as the component of the sympathetic fibers for the pain, especially originating from osteoarthritis and other degenerative conditions. So you need to think, you need to block femoral, you need to block sciatic and the obturator components. Where can you do it in the best possible way with the least amount of motor function impairment? We need to think multimodal versus multi-neurophysiological target model. Rather than saying regional anesthesia to the medications, you need to see which nerve I can block for which component of the pain. This is my take on the possible motor sparing analgesia, which I am doing for all my patients. They all start walking within a couple of hours' time. Why I use that, I will tell you as well. So I do the 4-quadrant genicular nerve block anteriorly. This is the sensory innervation of the capsule anteriorly. I use 0.375 to 0.5 depending upon the patient size. I use the one bupivacaine with the adrenaline, maximum 10 to 15 ml, depending upon the size of the knee. For chronic pain, we use 1 ml for the injection, but for acute pain, you need analgesia lasting for longer. So I use a higher volume. So 3 to 4 ml each quadrant. The IPAC block, conventional IPAC block for the posterior innervation or the posterior genicular nerve, plus the posterior plexus as well, you need to catch the posterior component of the obturator nerve as well. That is why the IPAC is added. Again, same, about 10 ml, but I use lower concentration. The saphenous and the anterior obturator nerve at the distal part of the subsartorial canal. So when you say this, we need to catch the anterior component of the obturator as well. Again, I use only 0.125% so that I do not get any motor involvement of the vastus medialis. I look for the femoral cutaneous branches for the skin incision in a thin patient. If I have, like, most of the patients that we get, I get really high BMI patients where I struggle to see the cutaneous branches for the skin incision. So I go and do a conventional femoral but a sensory block. So I use 5 to 10 ml of 0.125% chirocaine. So the surgeon do not infiltrate even a single drop of local anesthetic to the joint. Because when you put 60 ml of local anesthetic around the tissue, you can imagine you produce a lot of inflammation and the tissue swelling there, which is not the best option for the tissue healing afterwards. This is more literature if you are interested. This is all coming out, lot of literature coming out in the acute pain world, and I'm sure there will be more RCTs coming in. And whenever we are planning any RCTs or any prospective studies in future, please don't compare something like adductor canal versus genicular nerve blocks. It won't serve the purpose. It will be comparing apple to pear. We need to do what is the, for example, spinal anesthesia, intrathecal anesthesia, adding all your sensory branches to it, whether that makes any difference. Because that will be the true difference for the patient's outcome later. The other outcome would be persistent pain after surgery, because this is the weak one that we need to target these patients. Thank you very much for listening, and have a wonderful, thank you.